come home.
I couldn't see it anyway.
Yeah, the whole black
Yeah.
Okay, y'all ready?
No.
You have to put your thinking caps on today, so I'm not going to do your work for you. You're going to have to think. See, Nick does this to you. He writes those little big letters.
So you're going to blow that up for me.
Yeah, I know.
Can you move up front?
This one.
I'm sorry, Steve. Can you go pick me up a program?
There's danger to being on the front row. Okay, a 40-year-old man arrives at the ER, accompanied by his family. He's complaining of palpitations after working outside for several hours. His assessment is as follows. What things are you going to want to know about his, what assessment do you want to do on this
Do
patient?
you have any cardiac history?
Okay, let's start from the top to the bottom, okay?
I got my gloves on.
I'll give you a hint.
Safe.
Yeah, it's kind of like that. Go down to primary assessment. So you want to know what his mental status is, right? Now, if he's got palpitations, is he unconscious? Is he conscious? Is he alert and oriented? So we want to know that first. So what's
He
next?
arrives, is he on the
Hey, I didn't write this. Okay?
He walked in, so he's good there.
No, well, he arrives with his family. Maybe they drug him in. Here, I'll tell you what. I'll erase this part, and I'll say you arrive at his residence and his family's there. How's that? Okay. He's laying up on the couch. So the first thing you want to know is his mental status, right? Why is mental status important?
So we can tell you going to
Yeah. What's his perfusion like? What would, if he had a severely altered mental status, what might that indicate to you besides just he's fully perfused? We're looking for that one, that initial. We're looking for.
Cardiac output.
Cardiac output. So his mental status will be directly correlated to his cardiac output, right? If it's a cardiac patient. So what else you want to know? Yes, respiratory status. He's breathing 22 times a minute. No difficulties. What does CTA stand for? Clear to auscultation. See there, clear to auscultation. So he's breathing okay. What do you think about 22 times a minute?
It's a little elevated, but it's okay.
It's still within.
He's probably scared witless, you think? His heart's racing with him.
What's his SpO2? That's the test.
I'm going to set it at 96%.
Well, then he's fine.
Yeah.
He's breathing really good.
Maybe he's got a carbon monoxide poisoning.
If he was working outside, he wasn't working in a closed space, so.
Does it say he was working? Oh, he's working. Okay. What can I say? All right, next. You're checking his pulses. He's got strong peripheral pulses. So what does that tell you? He's got strong peripheral pulses. Yeah, you can feel him, then his cardiac output is decent. Blood pressure of 125 over 80. You good with that?
This is great.
We don't get rate during our initial assessment, do we? Is it fast, slow, or non-existent, pretty much, what you're looking for, right? We just know that it's strong. This is all it Nick gave us,
Well, we can call him.
okay? The skin, see how we're going here? We've got his mental status, respiratory, going to ABC. Skin, he's hydrated, but he's pale, but he's warm and dry.
Why did he call us?
He's got palpitations.
Okay.
The heart's racing. Now, if you guys feel like you need to take notes about this, you're welcome to do that. We're going to move through this, so I'm not revisiting this page. Here's the rhythm. So you're going to have to identify the rhythm, and then we're going to decide about how we're going to manage it. All right. Oh.
Y'all cheating over there.
I'm telling you.
Are we supposed to ask him to click?
Not yet. I want you to look at it first.
We'll from out loud all said not. Now we're not thinking out loud.
When you're looking at tachycardias, there's a break point on tachycardias too. What is that? If it's 120, 130, we're going to treat it differently. Then it's if it's 220 or 230, right? It means something different. So make sure you look at this. You need to kind of have a good idea. Is it too fast or is it just fast? what's the other key you're looking for here?
No P wave.
P wave. If there's a P wave, what do we know? Yeah, if there's a P wave, it's a sinus rhythm. If you can't see the P wave, then you're not sure what it is. So if it's too fast for a P wave, then we're going to have to call it what? Okay. All right, I guess this is his slide here. Polling is open.
I bet you it's the same.
Yeah, see, it's bad.
Torsades is not.
It's wrong. Of course, yes, Torsades ain't up there.
Torsades is not an answer. And I can see it too.
This is gonna be a long day.
Who wants to pick torsades? Raise your hand.
We all
You're going to have to explain it. What is it about this strip that says torsades?
We were just joking.
I just want to know. I want to know here.
Nothing you die.
Of course, we did just give you the answer, right? Okay, more to know.
Okay.
After careful assessment of this patient, is he hemodynamically stable or not?
Or no.
Or not? I think you get to vote again. Did you already vote? Man, we got more votes. We got people in here.
Uh-oh.
That's okay. Let's talk about it. What says he's stable? What says he's unstable?
Well, I get a strong pulse and blood pressure.
Strong pulse, blood pressure's good. Top of the list is,
He's got his own consciousness.
yeah, he's alert and oriented. That's a good sign. So we're looking mainly, I look at mental status and then what his blood pressure is. He's got a good blood pressure and he's alert and oriented. That tells me he's probably pretty stable. Now what if he said he had 10 out of 10 chest pain?
He's unstable.
This is a whole different algorithm.
Yeah.
Do what?
It's a whole different algorithm.
Please.
What algorithm would that be? The chest pain algorithm?
Yeah, it's chest pain algorithm.
Yeah, if your patient has 10 out of 10 chest pain and he's real diaphoretic, then you might look at maybe he's unstable. How unstable is he? If he is a severely altered mental status, his cardiac output is, in the 90s or the 80s, now is he unstable or not? Yeah, he'd be unstable. So did y'all pick your answers? Yeah, we did that. Okay. All right, for this patient, the one we've been discussing, what's going to be your first line of treatment? This is not a group discussion.
We're just making fun of each other.
We're pretty bad at group.
Well, I'm sure that's easy to do.
Wow. Jeez.
Well, y'all do it frequently. You're quite good at it.
No, I need some like briefing.
All right, let's see what we picked. Okay. The ones that want to give us a Denison, they just can't wait to get in there and do something fun, right? I know how it is. Answer. Oh, he didn't give you the answer.
It's the green. What's the green?
Oh, is that okay? I like the little arrows. Okay, all right. I'm sorry. I need a nap. Yeah, so almost a quarter of you picked the wrong answer there. But these are algorithms that are going to give you guidance on what to do, but it's going to be your job to look at the presentation of your patient. It may be that you would start with a Denison if, if you've got everything in place and you're ready to go. Vagal maneuvers are never wrong. You always want to start with those, but you're going to make a decision sometimes on how quickly you're going to move from a Denison to possibly going on and synchronized Cardiovert. Okay, you've performed vagal maneuvers, and there's no change in the patient's heart rate and rhythm. What is your next step? How many have we been getting? I thought we had more than 15. I thought 18. Who's not playing? All right, let's see. Okay. How often does a patient convert at 6 milligrams?
If I
Hardly
remember how
ever.
many times I've seen it, 100%.
Really?
Yeah.
You've had it converted on 6? You're lucky. It's very unusual. I thought when they changed the algorithm, they'd change it to just 12-12. Let's see. Would you consider not using adenosine and just doing vagal maneuvers based on the presentation of your patient?
Maybe if you forgot to check your truck off and your insulin was expired.
Or you never got an IV, maybe. Yeah. What is it about your patient that makes you go ahead and push forward?
His heart was 260.
His heart rate's too fast, and that's going to eventually affect what? Cardiac output. Yeah.
Let me ask you this.
Okay.
You said if you didn't give an IV, you should stick to, that's a possibility. But if the patient does convert that line to a infusion, you're gonna need the IV. So you would really not want to go to electricity without having an IV.
Well, if you don't have an IV and he is conscious and alert and oriented, are you going to drill him? Is that what you're asking?
No, I'm saying, sir, you need an IV before you go to electricity. Right?
Yeah.
I mean, if you stop that.
Yeah. Well, in the worst case scenario, if I couldn't get an IV, despite several attempts and several people trying to get, I still didn't have an IV, and your patient was very symptomatic, then yeah, I'm probably going to line him up without one. But then, if you kill him, then you can drill
Yeah, then
him.
you put an IO in. I mean, he's unconscious and he can feel it now.
Yeah, I mean, I hate it, but that would be your absolute, the absolute last choice. In this case, if you didn't have an IV, for this patient, what would you do? Just what? What?
Got a bagel down
Yeah, all right, your transport time is 12 minutes.
Monitor.
All right, so what would you do for your patient? This is your patient, you don't have an IV, you've got him on oxygen, right? You've got him on the monitor. Anything else you want to do?
I put the pads on it, monitor and run the video.
Let me put these pads on you. Yeah, I told you to do that.
converts to a shock absorber.
Yeah, if he, as stable as this guy is, he's pretty close to being stable, right? It's a fast heart rate, but his blood pressure is still decent, and his mental status is still decent. If I don't have an IV, I'm probably going to go ahead and transport and give him some oxygen and kind of keep my fingers crossed with that.
Some Hail Marys or holy water.
Do what? Yeah,
Hail
that
Marys
too.
and holy water.
Yeah.
One size.
All right. However, because you guys are so good, you did have an IV in place. So you give 6 milligrams of adenosine with no effect. Well, now 12 milligrams of adenosine is given. The patient develops severe chest pain. His vital signs are 220. Well, I guess it's come down a little bit. You can't get a blood pressure. The pulse is really weak. The patient's mental status is deteriorating. All right, what you gonna do?
Punches the heart real hard.
All right, a couple more of you. You can hold them out on me. Let's see. Okay, some of us are just gonna just flat out defibrillating, right? Who's that? By the way.
Alright, so on 3. 1.
Yeah. Yeah, actually for this, we're going to do synchronized cardioversion. Y'all remember how to do that? How does synchronized cardioversion different than immediate defibrillation?
It sets off on the R wave.
Yes, at the peak of the R wave is when synchronized cardioversion is going to take place. What's the difference in cardioversion and defibrillation?
Defibrillation is
The million.
Huh?
and it's a different.
Yeah, the main thing is going to be less joules. But yeah, we want to do synchronized because why?
Because you're more likely to get conversion.
Yeah, you're more likely because of where you're going to give that energy. But what's going to be the bad outcome if you get a bad place? Where's the bad place? Yeah, the down slope on the T-wave, if you hit that, you're probably going to put it into cardiac arrest anyway. Yeah, we know what to do then, huh? All right. What was the deciding factor when determining if the patient required continued pharmacological intervention or if the patient required electrical therapy? Yeah, we'd gone through that part of the algorithm. We'd used 2 doses of adenosine. That's right. Would you have stopped at the adenosine and not done the, not used electrical therapy, not cardioverted?
You could do amiodarone, carbazine.
Now, for this guy, would you have given him a sedative before you synchronized cardioverted him? We do at least have an IV for this guy. What would you give him? How much?
5 to 15 titrated effect.
What would you start with?
5 to 15. It's 5 to 15 on a book.
Oh, but you're not saying you always start with 15
No,
for
5 to
yourself.
15
Was he a large guy, small guy?
Is it me, or is it
Absolutely.
like Ashley over there? There's a difference. It might take 15 to
Yeah, so your starting dose would probably be what? Probably 5 milligrams will do it for you. All right, what are the steps to performing a synchronized cardioversion? Tim, you want to come cardiovert our patient? Hey, Steve, can I shrink this down and bring the other thing up, or do I have to close it and bring it up? So is it simple enough? I can.
Minimize that, but when you close the other one, you can get through that, come back to this, shut it down.
Oh, should I just wait and do it at the end? Huh? Maybe I'll just wait and do it at the end. Or we're going to go through the steps of synchronized cardioversion first when we finish this. So I'll remember what we're doing. What is the difference in synchronized cardioversion and defibrillation? We already did that, didn't we? Woohoo! We're ahead of that one. Synchronize is set to correspond to the R wave. I did put that on there. We want to avoid the relative refractory period if we possibly can, and we avoid that by synchronizing. So if you forget to sync your monitor, which people do, you might be working a code here pretty quick. That's the children. Don't be alarmed. Don't go running out of the building. After synchronized cardioversion is unsuccessful, okay, so you've attempted to cardiovert, it didn't work, the patient is now unconscious and has no pulse.
CPR.
This is what you have. That is not. What is it? What?
VTAC.
All right, I'm going to take a vote here. So y'all are scaring me. All right, all in favor of course VFib, raise your hand. Come on, y'all, man up. I heard you saying it. Come on, who thinks this is course VFib? I want to see you.
I'm riding
New fence around.
You got it. You got to make a statement. You might be right. Raise your hand. This your course VFib. I want to see it. All right, who all thinks it's, what's the other one?
VTAC.
Oh, VTAC. Who thinks it's VTAC?
I think it's course I.
Okay. All right. Y'all scaring me. Oh, wait. I thought you were supposed to pick. I guess they didn't give you. There's no kind of fib here. If you can see any type of consistent shape, of which these are pretty consistent shapes. I mean, I can pick out some that are identical across here. That's pretty consistent. This is going to be VTAC. What kind of VTAC? Pulseless VTAC. Pulseless VTAC. Because our patient doesn't have a pulse, right? Y'all scaring me. What's your next intervention here?
He's already on the defibrillator, isn't he? Because we shocked him once, right? And then we sent him in there.
I wouldn't say we shocked him once. I would say we what?
Or we cardioverted.
Okay. Y'all all pick your answers? I'm short a few. Come on, who's not doing? Who's not playing out there? You're not playing. Well, this is interesting. All right, let's see. The most popular answer was begin CPR. Why don't you begin CPR?
You witnessed it.
Witness. This is a witnessed arrest. You're sitting right there. You saw it happen. So there's no need to do 2 minutes of CPR or whatever. So we're going to move directly to, let's see, what was the next most popular? Oh, the next most popular answer, 20% was correct. One unsynchronized shock. So you're just going to line him up one time, and then what?
Check for, no, begin
Why don't we check for a pulse here?
because you don't do that right after you cardiovert.
Why?
Because you
start
just
CPR.
lose it.
Because
Not
why?
strong enough to
Yeah,
do it.
Yeah, right after you cardiovert, you defibrillate, even if he converts, it's going to be a little bit of time before you can feel that pulse. He's not all of a sudden going to have a perfusing rhythm. You're not all of a sudden going to feel a pulse. So you're going to do some CPR, and then you're going to check for a pulse. Okay. The patient does not respond to the defibrillation at 120. He remains pulseless. What is your next intervention? All right, let's see. Okay, I'm starting to feel a little bit better now because I just told you that answer. So, yeah, so you're defibrillated. You're going to do your 2 minutes of CPR, right? We're not going to push our drugs yet. We just said we're not going to check the rhythm and the pulse. We're not checking the pulse yet. I just said that. Who picked that? I need to know this stuff. All right, after completing your 5 cycles of CPR, your rhythm check indicates shock advised. You shock a second time at 200 joules and the patient's rhythm does not change. Oh, he didn't have a rhythm. Oh, no, he was in VTAC, wasn't he? You resume CPR. While completing the cycle of CPR, what else should be done?
Does he already have an IV?
Yeah. Yeah. We pushed the Denison.
Just confirming, you know, make sure I want to pick the right answer here.
Unless you pulled it out by accident.
That's a possibility.
That's a possibility. Okay. A or B. You can use epinephrine or vasopressin, whichever one. You have a question, Brian.
I have a question. We were told last week if you use vasopressin, you can't give anything for 20 minutes. Is that right? You can't give epi again or anything.
Well, if you give vasopressin, you're not going to give epi. I don't know that you can't give anything. Who told you that?
Yeah.
Nick said he had
Kind of
looked
rule of thumb on vasopressin on that 20-minute rule.
Can't give anything else?
So if you get, so
I know you can't give epi.
So why would you use it for the first dose? If that stops everything you would say to do?
Well, that's not everything. I'm pretty sure it just stops the use of epi.
That's what I
You
thought.
can't give anything.
I thought it just stops use of epi.
well, vasopressin has a longer half-life. Actually, I looked up this weekend at work. It has a 10 to 35-minute half-life in the body, while epinephrine only has like a 2 to 4, which is why you're doing it so often.
What you would do is like vasopressin, if you're in the back of Walmart and you gave it back at Walmart, by the time you loaded them, got them to your truck, got on the way, then you could switch to epi. You get the vasopressin first, you know, because you've got a
Gotcha
long
time.
delay where you're not going to be able to give drugs. You see what I'm saying? You're out in the woods or something like that, but you can go back to epi.
Within 20 minutes, or do you have to wait?
Yeah, I would. They say 20 minutes, but
We need to make sure we're sticking with the book. I
Exactly.
can tell y'all that right now.
Yeah, absolutely.
Whatever the book says is what we got.
He said he check. I'll check on that too. I'm not aware that you can't give anything. I know once you give vasopressin, epi's pretty much out for and that's why you give vaso. You just give it and then you're done with that. But it's my understanding you can follow up with other things as necessary.
Yeah, it's not, it's only.
amiodarone and lidocaine and
Yeah.
whatever.
Things like
Yeah,
that.
you can give that. It's just,
It's going to be either epi or vaso. You can give one epinephrine, it wears off, then you can come back with vasopressin. Really, it's going to depend on what you get out first and what you got on your truck and what your medical director wants you to do, because there's a choice there. And sometimes they will tell you, okay, for first dose, I always want you to go with epi, then I want you to follow up with vasopressin. Then you do it that way. Or if he says, I want you to start out with vasopressin and be done with it, then you do that. So, but I'll check on the rest of that. I'll ask him where he got his information. Vasopressin, that should be done. Yeah, you can do either A or B. Somebody pick C. What's wrong with C? The dosage is incorrect. Okay. All right, you've given the epinephrine or the vasopressin and completed the 5 cycles of CPR. A rhythm check reveals no change, which means what? He still has no pulse, right? Oh, the rhythm check is still what? Pulses VTAC. You attempt a third defibrillation. What will be your biphasic defibrillator setting?
Whatever you just said it for.
Come on, y'all, finish up. We're all waiting on you. Good job. Okay, yeah. Where's 300 joules come from?
Monophasic.
We're doing 200 joules for our third defibrillation. 300 would be the middle on monophasic. What's the top on monophasic? 360, yeah. So we're beyond the 300 on that, so yeah. Okay, the third shock does not change the rhythm, and you restart 5 cycles of CPR. You've shot, you've given your pressors, you continue with CPR. What medication would be considered at this point? Who picked dopamine? Tell me why you picked dopamine. Y'all scared? Embarrassed you? Probably. Yeah, here we're going to give amiodarone. What's going to be the dosage of amiodarone?
300.
Okay, 300. What's second dose of amiodarone? Okay, just checking. And why would we not give dopamine? What does dopamine do? It's going to increase blood pressure, which we have none already, right? And it's a pressor, so it's going to vasoconstrict. That's not what we're looking for. We're working on the heart right here. What is the correct dosing for amiodarone in pulseless arrest algorithm? See, we already did this. This will be easy for you.
One dose of 40 units may replace first and second dose of epi can be administered every 3 to 5 minutes during cardiac arrest.
Yeah, but it's not talking about in between vasopressin. Good job, guys. Okay, lidocaine, Anthony. Lidocaine can be used instead of amiodarone as an antiarrhythmic for pulseless arrest. What is the proper dosage of lidocaine in cardiac arrest? I'm going to have to think a little bit here.
1 milligram per kilogram. Okay.
Come on, a couple more. You finish up here. Okay, some of you read that. Yeah, the dosage is 1 to 1.5 milligrams per kilogram. So you're going to have to do that math pretty quick. And then half that dose for your follow-up dose. And your patient converted. Whoopee! After administration of amiodarone, 300 milligram bolus, the patient converted to a perfusing rhythm. You should now consider starting an amiodarone infusion. Formula is 360 milligrams IV over 6 hours, and then 540 milligrams over 18 hours. But hopefully we're not going to be doing that. If I've got that patient for 6 hours, one of us is going to die. Tell you. It's terrible. Great job. You saved the patient. He's been stabilized and intubated, but he does not respond to verbal commands. He's transported to the hospital's ICU. Since the patient is not responsive, what will be the most important intervention in the post-cardiac arrest phase? Y'all foot dragging on this one. Come on, some of you guys. Pick a winner here. Well, that's interesting. Did y'all not go over this?
Yeah.
Okay, some of you slept through that. Yeah. Current practice is doing induced, or what they call therapeutic hypothermia. There are some services out there in the United States that are actually trying to start it in the field. And hopefully that'll be here one day. They've found it's very effective for cardiac as well as stroke patients. So therapeutic hypothermia is a big deal. It's worth doing some reading on. They're doing it over at East Alabama, aren't they, Anthony?
Dr. Cool.
Dr. Cool is cooling his patients, same thing? Is that what you call it?
That's Dr. Cool protocol.
Okay. Well, that's good. At least they're doing it. Okay. Next scenario. Y'all ready? We're going to start another patient. Y'all okay? Do you need a break? Let's roll. Okay. Y'all got to stay awake. Okay. This time we're going to let this be a field one. Respond to the home of a 65-year-old female who is now unresponsive. Family states she began complaining of chest pain and she passed out. You're unable to palpate a pulse. Patient does not have spontaneous respirations. This is your patient's rhythm. Name this rhythm. So, does it ask me what it is? No. What's this rhythm? PEA because there's no pulse. Okay, good job. Cause of PEA. Have y'all been over this? I asked Nick about it yesterday, and he says that they touched on it maybe in advance. When you have a patient with PEA, you want to look at some of the causes, the underlying causes of PEA. So hypovolemia, what about hypovolemia can cause PEA, you think? Hypovolemia, you don't have enough blood circulating through there, you're not getting enough oxygen around. Hypoxia, oxygen. Hydrogen ion acidosis, what does that mean? What is a problem with a hydrogen ion that makes you acidotic? What disorder makes a patient acidotic? DKA, diabetic ketoacidosis. Good job. So you'll be looking for that. So how would you test for that?
Check sugar.
Yeah, check a blood sugar. Good idea. Hypo or hyperkalemia, that's going to be based on history. Hypoglycemia, we can check that too. Hypothermia, some of your patients that are hypothermic may be in PEA. Toxins, what does that involve? Could be. Yeah, oftentimes these are going to be drug ingestions, either deliberate, more commonly deliberate. Tamponade, cardiac tamponade. You know, anytime you've got that pressure on the heart, you can cause dysrhythmias. Tension pneumothorax, pulmonary coronary thrombosis, trauma, of course, increased intracranial pressure. All these can be causes of PEA. Some of these things you can reverse. So if you've got a patient with PEA, you want to be able to move through quickly your H's and your T's. You're going to have to know these moving forward. So if you don't have them written down somewhere, you haven't started learning them, this is kind of like your OPQRST, your sample history, your H's and your T's. So you're just going to have to learn those. You will see those on National Registry. If they give you a scenario with a patient of PEA, they may say, you know, which of the following should you consider as a cause? You got to know your H's and your T's.
Hey, let me read you this about vasopressin. This is from the Alabama Protocol. This is from American Heart. American Heart, cardiac arrest, 1 dose, 40 units. Push may replace first or second dose of epi. Epi can be administered every 3 to 5 minutes. Think about that. What did I just say? First and second dose every 3 to 5 minutes. So, under Alabama Protocol, vasopressin is given as a one-time dose and may substitute for the first or second dose of epi in the setting of cardiac arrest. After vasopressin is given, further dosage of epi should continue to be given as indicated in the cardiac arrest. So what that's telling you, you give epi every 3 to 5 minutes. Vasopressin, it takes the place of the first 2 doses. So within 10 minutes, you could give epi again. Basically between 6 and 10 minutes. That's where I'm saying it's a good dosage for your first dosage, because you give it on scene and then you're not going to work it on scene and you're moving them to the truck. Then it gives you time to get them into the truck, set up, and then you can go back to epi. But it's a one-time dose of 40 units.
Okay. Y'all have these causes of PEA written down somewhere, right? Just like you had to learn your algorithms, you're just going to have to know this. Okay. After determining your patient is in a bradycardic rhythm, will require intervention. Is this the same scenario? I've lost myself. After determining your patient is in a bradycardic rhythm will require intervention, the first step you should take is, okay, you've decided, for you to determine that he needs intervention, what does that mean you've determined? Yeah, we call that, yeah, are they stable or unstable? Right, so we've determined that he must be hemodynamically unstable, so we want to do something, right?
Is this supposed to be with this patient?
Is it the same?
Because none of those answers are right according to the algorithm.
65 minutes. Complaint of chest pain and passed out. You're able to palpate a pulse. Does not have spontaneous respirations. Or you're unable. So this patient's dead.
Yeah.
So I don't know what he was talking about. Our patient was in PEA. All right, let's pretend that our patient's bradycardic symptomatic, I guess. What are you going to do? I guess we're just going down the bradycardic algorithm here. I should have taught that. Maybe this is bradycardic PEA. We saw a sinus rhythm, but let's say it's bradycardic PEA. How's that? All right, everybody go. Answer is identify and treat the underlying cause. So yeah, I guess that rhythm should have been a bradycardic rhythm up front. We'll change that next time. So yeah, considering this is a bradycardic, you're going to look and see PEA, see if you can identify the underlying cause. What could be some of the underlying causes? What are your H's? Hypovolemia, hyperkalemia, hypoxia, hypothermia, acidosis. Are we missing one? Huh? Hypoglycemia. Okay, what are our T's? Tension pneumothorax, tamponade, toxins, trauma. Yeah. Something else? Somebody wrote those down, didn't they? Thrombosis. Good job. Okay, what's the first line of medication for bradycardia? This now, we're no longer in PEA. We're in bradycardia. How's that? I told you I didn't write this. First line of medication for bradycardia. Y'all miss this? I'm not calling 911 in this area. Not for myself or anybody that I know. Aha! Yippee! atropine, 0.5 milligrams, not 0.5 milligrams. Okay, if atropine is ineffective for your patient, which electrical therapy should you consider next? Okay, everybody? Okay. Who's going to transvenous pace? Y'all scaring me. Yeah. Not you and not me. Transcutaneous pacing. That's going to be across the skin. What are the steps to transcutaneous pacing? We're going to come back to that. Okay. What should be considered for a patient who's a candidate for TCP and is awake? Sedation, yeah. You need to get that on board pretty quick. So you better have your IV going. Sedation, consider Valium. What would be the different effect you would get by using morphine over Valium? Well, you would get a decreased respiratory drive most likely, but what does it bring to the table that you don't get with Valium? Yeah, it's an analgesic as well as Valium as your sedative. Morphine's going to be an analgesic. How would you describe the rhythm on the monitor? What rhythm was that? Should I make one up? Well, let's see what the answer is.
It was the very first.
Okay, that was PEA. All right. We're going to require some editing here. What should your immediate intervention be?
I guess now we're back to the beginning.
I guess we
Which one
are.
is it?
Yeah, I have a trouble tracking sometimes. I told you I didn't write this. All I did was correct some spelling. What should your immediate intervention be?
Are we back to PEA?
Yeah.
Okay.
Back to PEA. All right, that was your patient on the monitor. It would look like a normal sinus rhythm. There was no pulse. Immediately you should what? Anybody else? Last chance. Thank you. Yeah, anybody that doesn't have a pulse? Doesn't matter if it's PEA, they're getting CPR. And what IV medication would be appropriate to use in this scenario? This would be your PEA patient without a pulse. What are you doing down there in your lap? That bothers me. Lap looking during class bothers me. That's okay. I want you to like not be in the ozone somewhere. Okay, somebody pick the old Epi 1 to 1,000, which we use for what? Anaphylaxis. Okay. Who's treating our patient for anaphylaxis? Somebody?
We ran out of the 1 to 10,000.
I've used all my 1 to 10,000, so I'm going to like convulse you with a 1 to 1,000. Okay, this is the bradycardic algorithm. Y'all all have a copy of this, don't you? You all have your little
Now
flip
back to
books?
bradycardia.
And we're all going to go and learn that this evening, right? Okay. Good, yeah. There's still time. You can come back tomorrow. This is the tachycardia algorithm, tachycardia with pulse. Cardiac arrest algorithm. This will be posted on the website, so if y'all want to go back and like look at these, you can do that. I'm not going to go through those, you know this. Post-cardiac arrest algorithm. You want to keep your O2 sat at or above 94%. Do not hyperventilate. What do you want to keep the blood pressure at? You want to keep it on the low side there, but you want it over 90. Consider therapeutic hypothermia. Ta-da! Do what? Did I miss something? Hey, you guys take a short break. When you come back, we're going to go through pacing and synchronized cardioversion, okay?
So, you should-
Let me stop this.